Welcome, everyone. Good morning, good afternoon, and good evening. My name is Michelle Monroe Kramer, and you are here for our third session of the 2025 Coffee and Conversations. So today we are excited to welcome Joseph Sieka. Joseph was actually a visiting scholar at the University of Michigan School of Nursing, and he's come back a few other times to visit us and see us in person. But he's joining us virtually today from Liberia. And Joseph is a lecturer and deputy director for research at the University of Liberia Center for Teaching, Learning, and Innovation. He obtained his MD from Liberia's only medical school and a Master of Medical Sciences degree in Global Health Delivery from the Harvard Medical School. His research project focuses on increasing access and quality of maternal health services using the WhatsApp platform and a midwife-led obstetric triage in Liberia. And he's worked very closely with our colleague, Dr. Jody Laurie, as well as others on this call. So I am going to go ahead and share Joseph's presentation. And then again, you can, if you have kind of time-sensitive questions, please feel free to use the chat or the Q&A throughout the session. Otherwise, we will have time for some conversation and questions at the end of Joseph's presentation. And I see a few people have already started to do it. You are welcome to introduce yourself in the chat. And then if you would like to use the closed captioning function, that is turned on, and you can change the language that you see the captions in if that's something that you would like to do. All right, I am going to go ahead and share your screen, share my screen, and turn it over to you, Joseph.
Thank you, Michelle. So, good morning, good afternoon to everyone. I see a number of faces that I'm familiar with, and some of you I've not met in person, but welcome. As a result of some funding from the Bill and Melinda Gates Foundation, Professor Laurie and Dr. Dan collaborated on a Millennium Challenge project that resulted into the study that I'm going to describe shortly. Basically, it was integrating a WhatsApp triage with a standardized obstetrics triage to reduce the delays, especially the third delay at the health facility when a woman gets there. Next, Michelle. Next slide. Okay, so to provide a little bit of background, in Liberia, a country of just 5 million population, we have one of the worst maternal mortality rates in uh, the region, in our region, in West Africa, or even in sub-Saharan Africa. According to the most recent data, our MMR stands at 661 deaths per 100,000 live births. And some of the challenges that Liberia faces include natural as well as structural uh, forces. We've had a bitter 15 years of civil strife that decimated our health care system. We had the Ebola pandemic together with 3 other West African countries. And we've also had a bit of COVID-19. Our socioeconomic indexes also do not portray a good picture. More than half of our population lies below uh, the poverty line in abject poverty. Maternal mortality disproportionately affects uh, young women as well as women in the rural part of our country. Our study was piloted in a central county, Bon County, which is basically a rural setting. Next. So I'm going to use the 3 delays model, which is widely accepted in obstetrics care, um, to conceptualize the various delays. The personal, which will fall in the first delay, the delay in making decision as to whether to seek health care. Then the pre-hospital delay, that includes when the decision to seek health care is made, the means of getting to an adequately sourced hospital, and of course, the intra-facility delays too. So we will use this framework to address the various kinds of delay that have been so widely classified. Next. So for the study outline, we'll look at the background, uh, the objectives, methods, results, discussion, and conclusion of our research, even though we are still writing some of our manuscripts as of this time, but by and large, we have come to some definitive conclusions about the intervention that we employed. Next. So the problem is that widely across the health sector in Liberia, we do not employ a standard triage system. Right after Ebola, generally for non-obstetrics patients, there were triage standards that were established, but non-specific to obstetrics. They were really specific to infectious diseases. So if somebody came with a temperature, people would know exactly how to approach a patient with a high temperature. But routinely for pregnant women, each facility would just have a way of assessing a particular patient, which would not even be standardized across the same facility because each individual health worker had a different approach to how they would assess a patient. And because of the lack of a standard means of triaging pregnant women, we also noticed in our formative research that there were a lot of delays when the woman made the decision to get to the facility. When the woman got to the facility, there were still delays that you will see are very unacceptable and were also related to some of the maternal deaths that the country is plagued with. So there are evidence that a standard triage system is directly related to inadequate or absent, is directly related to maternal deaths, and the absence of triage system also is directly proportional to the number of deaths that country experiences. Next. Can you go to the previous slide? Okay. Oh, the one after this one. I said jumping over a slide, but okay. Anyway, the bottom line is that there are low-hanging fruits that our intervention recognize. First, the absence of widely validated solutions that are being employed in settings similar to ours, such as the obstetrics triage and the use of mHealth. For our case, we use the WhatsApp platform to uh, connect facilities to the community and to the district referral hospitals. Next.
Joseph, do you want me to go to the setting one?
Come again?
I think we skipped this study setting. Do you want to go through this or should I go forward to the
Yes. Okay. Yes. So Bone County, where we conducted the study, essentially is our third most populous county. As the as progress over the years, especially since the Ebola crisis, some progress has been made. In 2020, for example, we had 84% of women being delivered, pregnant women being delivered at the health facilities by skilled staff. So the question, or what begs the question is, if we have this high rate of facility-based delivery, why is maternal mortality still high? And that's the reason why we're interested in finding out what the magnitude of the third delay is, that is the delay once the person gets to a health facility, and to understand what factors, what processes could be designed to mitigate the third delay. Next. So we use a mixed method study with qualitative and quantitative components. In the qualitative component, we did a baseline, just participatory study design, and we conducted in-depth interviews and focus group discussions with health workers to just generally get a feel of how things were in Bone County prior to training and any intervention. So just go to the next slide, Michelle. And what we're trying to learn during the formative or during the qualitative assessment was to find out how the triaging system, if any, was. We did a needs assessment of community health assistants who are the catered of health workers that are at the community level. Basically, what they do is that they facilitate the first level of referral to rural health facilities. They do some basic risk assessment. They've been trained to do that. So they will want to find out whether a pregnant woman is bleeding, whether she has edema, uh, whether there are visible anemia and those other dangerous signs. Then she's referred to the nearest rural health facility. And if they are not able to intervene, then they also refer to the next facility. So what we did during this phase of our intervention was to train the CHAs in the use of the WhatsApp platform. And unfortunately, during the actual intervention, this link, the use of the CHAs was not forthcoming because we did not want to provide smartphones to CHAs. We wanted for people to use their own smartphones, and we will just support them with data for internet. But majority of the CHAs in the intervention facilities did not have smartphones. So that aspect of our intervention wasn't actualized. But we had 20 rural health facilities, midwives and nurses with smartphones. We established WhatsApp network amongst them and together with the CHAs, even though that aspect didn't materialize. Then we conducted in-depth interview and focus group discussions with healthcare workers and some caregivers. Next. In phase two, we focused on the nurses and midwives at the rural health facilities. They were trained. In fact, we trained them first, and they trained the CHAs. We assess people's ability to use the WhatsApp for communication, and in cases where their knowledge was rudimentary, we gave them hands-on instructions on how to use the WhatsApp. And during this phase two, also, we had 2 trainers from Ghana, a country which had, prior to our intervention, used this obstetrics triage, come to Bon County, and they trained 5 trainers. Those trainers, in turn, trained their counterparts at the other district hospital. During the same phase, we also conducted pre and post evaluation. We wanted to determine what the wait time from the time a woman arrived at a health facility to assessment to diagnosis, and what was the interval between the decision to cesarean section and the actual cesarean section itself. We also collected data on complications and on the outcome of out of the cesarean sections during our baseline, midline, and endline observation data collection. Then finally, also after our intervention, we also did a survey, post-intervention survey, to assess the acceptability, feasibility, usability, and overall satisfaction with the WhatsApp system at rural health facilities and with the triage at the 2 district referral hospitals. Next. So basically, our interventions was this triage, obstetric triage implementation package that was developed by some US, um, some colleagues from the US and Ghana. And that's the reason why we had the Ghanaian trainers come to our facilities to roll it out here. So we did pre-facility assessment prior to the rollout of the training. And like I said, we have 5 champions midwives that are our local trainers in Liberia. And the research at the 2 facilities involved 62 midwives and nurses, especially those working in the emergency department and the OB units at Phoebe and CB Dunbar hospitals. Next. So how did we achieve this? We established a network of CHAs and midwives. We provided internet support through the purchase of communication cards. The GSL, you do not directly subscribe to GSL company in Liberia. If you have a device that needs internet, you purchase communication cards. So we purchased those and provided that support to midwives. And we train health workers in the triage centers that I've described previous. And we established a network of rural health facilities. Each rural health facility in a network with WhatsApp triage to one or both of the district referral hospitals, and we implemented the triage standards using color-coded wristband, and I will explain that later on. Next. So at baseline, what we noticed was that the median decision to deliver interval from the time the woman got to the facility was assessed and the decision was made to intervene through cesarean section, that interval was 177 minutes during the baseline data collection. At midline, we noticed, and this is after the training for the triage, it was 116 minutes. And at end line, the median decision to delivery interval was 68 minutes. Next. So during our interventions, we identified gaps in knowledge because the mode of training was a pre and post test type of rollout. And we noticed that the pre-test scores were significantly lower. And during the 2 days of the actual training, the post-test also show significant knowledge gain. We acknowledge that this is a positive result to improving obstetrics triage knowledge. And there was a decreased decision to delivery from baseline to end line of 68 minutes. The decision to deliver intervals are long in this setting compared to international standards and well-resourced settings, which is typically 30 minutes. And decision to delivery is a modifiable factor that can influence perinatal outcome. Uh, in our pilot, you see that we went from 177 minutes to 68 minutes. And we think this decision to deliver it interval can be even reduced beyond 68 minutes if the necessary staff, stuff, and systems are in place. Next. So after the training, the triaging system that we employed, we use color-coded wristband to classify patients. People who had, who generally we thought would have a normal course of labor were given the green wristband. Of course, the midwife understood that people in green still needed to be monitored. But upon the initial assessment, if there were any of these signs listed under yellow, that person will be given a yellow colored wristband. And if the person had any of these on assessment under red, the person will be given a red wristband. So somebody could come from green to yellow and red whilst they are in the hospital. But once somebody had either yellow or red, they will not progress to green because yellow and red meant they needed close monitoring. So you could only progress from green to yellow or red, but not the other way around. Even if you were yellow and you did not deteriorate, you still had yellow until whatever mode of delivery was indicated went through. And these are the topics that were covered also during the triage training, understanding triage, why midwives, why is triage assigned to midwives, managing complications, prioritization of care, and other topics. There were role plays, demonstrations, and group exercise during that particular training. Next. I'd like to give acknowledgement to Professor Jody Laurie, Dr. Bernice Dan, Wademe, my colleague here at the University of Liberia, who was a co-investigator, midwives, nurses, and PAs at the two district hospitals, and midwives and nurses and physician assistants at the 19 rural health facilities that conducted this, and to the Ghanaian trainers, Dr. Boama and Cecilia Tete. Next. So before I close, I would like to recognize broadly what we did achieve through the use of mHealth and Triage combined. Triage provided a standardized urgency assessment at the first point of contact. And the WhatsApp platform provided real-time communication, data sharing, and decision support. During the post-implementation surveys, nurses and midwife acknowledged the great support of the WhatsApp platform. The closed loop provided a feedback mechanism that they did not have access to prior to this intervention, because in real time they could get feedback from their colleagues at the district hospitals. Um, we also would say it in a broader health system strengthening manner that the use of the WhatsApp platform facilitated transport and preparation at the health facility itself. So when the district hospitals um, were told that a patient was coming from one of the rural health facilities, they will have adequate time to prepare, especially so if they had some provisional diagnosis. If it were a case of bleeding, they will set up for bleeding. If it were a case of preeclampsia or eclampsia, they will also set up before the patient even arrived there. And before our intervention, it was just a paper-based referral that the referral facility wouldn't even have an idea that patient was coming to their care. So the WhatsApp platform also provided an efficient handover at the receiving facility and mitigated some of the other delays that we saw in the metrics that we provided as the median decision to delivery time. One of the things that we've not scaled up, but one of the things I worry about is the fact that we've not scaled up, and also whether now that a number of years have elapsed since the closeout of our study, whether the gains that we made are still being implemented at the health facility level. Hopefully this year, in November, after all of the manuscripts are published, we'll have sufficient evidence to present to the Ministry of Health and hope that they can scale up these two low-cost interventions to other counties and eventually mitigate the high burden of maternal mortality across our country. Thank you very much. I'll be open to questions.
Thank you so much, Joseph. It was great to learn a little bit more about this project. I heard a little early on, and it's really nice to see how it's progressed. So questions, you can feel free to use the chat. We have a relatively small group, and so you're welcome to also unmute and ask your question. Or we do have a Q&A, but I think that the chat would work well as well. Any questions from the group?
Can I ask a question like this, or did you want me to write it?
No, go ahead, Sandra.
Okay. Good morning, Dr. Sieka. I just wanted to ask how long the training for the triage, like how long the training took to train the midwives and the nurses and how to do the red, green, and yellow.
Thanks for the question. It took 2 days. So the Ghanaian trainers train the champions, and in their presence, the champions train the other people just to make sure the quality was maintained. So it was 2 days of training.
Thank you, Joseph. While others are thinking of questions, I had a couple things written down as well. So Sandra, actually, who just asked the question, is very interested in kind of policy and scale up. And I'm wondering what components you think are necessary for the scale up. So obviously having access to WhatsApp on a phone, which you talked about for some individuals was a little difficult. The bracelets seem like they were helpful for the color coding. Are there other things that might be necessary as far as kind of like training manuals or protocols?
Yes. So I think with respect to the policy aspect, the main thing I can think of is the training itself, the triage training itself. Uh, so that even if people don't have access to using uh the bracelets, but if the training is localized, and we find means of enhancing the referral system by policy, I think that will be helpful.
And Joseph, I'm wondering if you could talk a little bit more about the WhatsApp access on the phones, because it sounded like that was a kind of a barrier or a sticky point for some of the CHAs, is that they didn't have the smartphones to be able to use the WhatsApp
So
function.
the rate limiting aspect about the WhatsApp is the internet support. Um, the most of the healthcare workers have smartphones, and all of the facilities that we implemented the project in also were facilities that you could get internet access at some point of time during the day. So the WhatsApp itself is not a problem, but the support to the rural health facilities for data. So one one of the things that we might be recommending is that we have two GSM companies in Liberia, and perhaps through their social corporate outreach to the communities, they could provide um, basic internet to help facilities to enhance the referral system.
Thank you, Joseph. That makes a lot of sense. Ibrahim.
Yeah, Prof. I have a question for Doctor
One,
about
one
this
minute.
issue.
1 minute.
All right, we lost our speaker. One moment. I think he'll be right back.
Okay. In fact,
Welcome, Ibrahim. It's good to see you again.
yeah, Prof.
While we're waiting for Joseph to return, Jen also put a reminder in the chat. If you haven't already registered, our final coffee and conversation for this year will be next Tuesday, June 17th at 8 a.m. Eastern. And we'll be hearing from some colleagues in Ghana about management of pain among young adults for sickle cell.
Call. So, but what's Lorena?
I think it will be very interesting.
I have to step in. Yeah. The message is saying he wants to know the names of people that are coming so that he can make arrangement for them. Okay. I will soon, this thing will soon, and please see how you can talk to him. Sorry, Ibrahim, go ahead.
Thank you very much for this wonderful presentation. Actually, in an Africa, there is a lot of maternal issues around, but addressing it is like there is a little bit challenge Yeah, I haven't about this presentation. Doug, I want to find out whether the training for the health workers, was it a workshop they did? And if it is a trainee trainer, after they gain the experience, how long did they train the participants? And whether the participants too were also ready to learn and also impact it to those in the rural areas? That's the question I have. Thank you.
Uh, sorry, I missed the first part of the question that wasn't too clear.
Yeah, I want to find out whether the training, those who came from Ghana to Liberia and added to the team to trainers program, if it is a trainee trainer program. So those in the rural areas, how did they get the training? Because most people could not join the live session, and I know there is a network challenge in most of the African countries.
Okay, so the triage training only occurred at the district hospitals and not at the rural clinics, right? The two district hospitals. So the Ghanaian trainers, when they came, we selected midwives from the two district hospitals, and it took them 2 days to train them. Then they in turn trained the first batch from one of the hospitals in the presence of the trainers. So after that, I think maybe 1 or 2 months in between, the trainers themselves, in the presence of Dr. Laurie, trained the rest of the other people, and the sections were just typically 30 persons in a section for the 2 days training. But it was only the hospital staff because the triage was only done at the hospital. Then for the nurses at the rural hospital, their training was in the full triage training, but just able to recognize danger signs, recognizing what their limits are, or cases that should be referred. So those were the two types of training, but all of them um, were trained in using a WhatsApp platform, which majority of the people already knew how to use. They were using for other things.
Okay, thank you.
Other questions from the group? Heather.
Yeah, I had a question. I was curious, and I don't know if from your study you could tell, but if you felt like one arm of the intervention was more powerful in impacting maternal, mortality, or did they truly work synergistically? So was it the training of the midwives and staff for triaging? Was it the WhatsApp, or was it really truly that it was both things that impacted?
So our assessment cannot tell the extent to which both impacted, but one of the things we wanted to measure, especially for the third delay, was the decision to delivery interval, and we think it is the triage that impacted that aspect because pregnant women were adequately triaged. The action that needed to be taken was taken much quicker than before. And people were not triaged on a first come, first served basis. people were triaged according to their presentations.
Yeah, that makes sense. I think I was just thinking with the complications of the lack of internet, smartphone access, etc. Maybe a great way to scale up the effect of your study is to train more staff for the purposes of triaging, since that wasn't in place before. Because
Yeah,
obviously
yeah,
internet, cell phone, that kind of stuff is always going to be a problem, right?
yeah.
Thank you. It was very interesting. I really enjoyed your study.
You're welcome.
Great question, Heather. Yeah, I had also written down a note, Joseph, if the group is planning to look at any maternal health outcomes. So I know you were really focused on the delay, right? To decision to refer, but have you been able to track that to health outcomes? I know when I worked with Dr. Lori a while back in Liberia, one of the other issues was that if people were referred, the referring clinic wasn't necessarily getting feedback on what had happened, right? Like what the outcome was for both the neonate and the mom. And so I'm wondering if you were able to kind of provide that feedback loop or track any of those maternal or neonatal outcomes as part of this study.
Yes, yes, we did, and some of the later manuscripts will be reflecting on that aspect of the study too. So we also are writing a paper on the various indications for cesarean section according to the Robson classification to know which one is more prevalent, and also to be able to track the outcomes of the cesarean section during our entire study session, both the maternal and the neonatal outcome, as a matter of fact.
Wonderful. I was stealing the papers, giving away the outcomes too quickly here. All right. Any other questions from our audience? Go ahead, Ibrahim.
Prof, actually, it's not a question. I am just adding up something. Working in the clinical session for a period of time, I have realized that I don't know your place, and I don't know where doctor's place in Liberia. But in Ghana here, few of we the clinical staff actually have a feel of or see the need and the importance of research. So I think as doctors conducting these maternal issues, I think he can impact more of the midwives so that they can get more findings as to how they will help and to reduce the maternal mortality in Liberia. Because I think with evidence-based practice, we can actually reduce most of these things. Because you could see that they will use transporting a pregnant woman from one place to another. That one to contribute a lot to our maternal deaths in Africa here, because means of transportation is a problem, because and also availability of experienced midwives in the rural areas too is a problem. I think if Doc and Co can't actually impact their midwives and also train nurses who are yearning, though they don't have the requisite certificate to practice as a midwife, but they can actually train them to perform the little tasks the midwives in the absence of a midwife. The nurse can actually perform to avoid certain dangers. I think it's good because I've ever worked in a place where there wasn't a midwife, my first postings, and I could learn how to, I consult my books and learn how to do simple delivery. And if the delivery, I think that the presentation of the fetus is above my knowledge, I used to do referral to the nearest biggest health facility to do the necessary healthcare. Thank you.
Thank you, Ibrahim. That's a very salient point. And in Liberia also, because of the fact that most of the maternal deaths originate from the communities in rural areas, the Ministry of Health now has a program where midwives have been trained. There's tax shifting to midwives who have been trained and are now called obstetrics technicians that can perform cesarean sections in facilities where doctors are not present. And it will even surprise you that most of these midwives now are the ones who are teaching newly graduate doctors that just maybe get general practitioner, that is, that get training, that get EMOC training for 6 months and are deployed. They count on the expertise of these experienced obstetrics technicians. So it's a system that is working both way. Also, in places where you don't have OBGYN specialists assigned. So you're right. Tax shifting is one means through which the government is using to prevent, yeah.
Thank you.
I mean, initially there was a pushback from doctors saying, how can you allow midwives to perform cesarean sections? But some of us who are believers in the system, I would point to them. You have nurse anesthetists, you have
Yes.
nurses that are cataract surgeons. So what's about cesarean section?
Yeah.
Yeah. You got midwife worker, mid-level people that are doing other things, that doctors do. So in our system, until we get the numbers, that super specialization that is in the West, we cannot adopt that kind of system.
Okay.
Go ahead, Heather.
I was just going to say, and I mean, it's, midwives are more than competent to do these types of procedures. And I think in the West, we overuse OBGYNs and we don't focus enough on midwives, and especially in rural communities. So I think what you're doing is perfect and it's amazing. And I think as a world, we need to recognize that midwives serve a very vital function. And in some ways, they have training beyond the scope of what OBGYNs have. But we've emphasized, and not that OBGYNs are not important, not that specialization is not important and fetal medicine is not important. There certainly are times that I think it goes beyond what the training of, most typical midwives are. But I would argue that we don't necessarily need that much specialization to care for, at the highest level, women in need, certainly.
Okay.
And I might be a little bit biased as I've been a practicing midwife for 10 years, but I will tell you, when you place midwives in places where they are competent to be there, magic happens, and true magic happens. It's you will see wonderful things happen when everybody works in collaboration and when everybody's respectful of the roles that midwives play and the things that they bring to the table. I have seen absolute magic happen when that is allowed to happen. So kudos to you. It's wonderful to see.
Thank you.
I think that's a happy note to end on. Yeah, there definitely are different ways to use midwives. There's some interesting, in the UK and in Australia. with their National Health Service, the way they're using midwives to really run whole obstetric wards and just call in support when there is a complication or emergency is really impressive as well. So we will end on this happy note for midwives. Thank you so much, Joseph, for your excellent presentation. It was really fun to hear more about the WhatsApp triage and referral service. I believe you'll be connecting with Sandra more because she is really interested in the policy piece and scale up and is talking to Dr. Lori about that now. Just a quick reminder again, Jen already put this in the chat, but our final coffee and conversation will be next Tuesday, June 17th, from 8 to 9 a.m. Eastern, and then adjusting it based on your time zone. And we'll hear from Abigail Ampansoa and Judith Noemshi on using cognitive behavioral therapy for sickle cell disease pain management in Ghana. We have really appreciated having everyone join us for these sessions. They're a great way to learn more about our colleagues' work in a bit more informal space to have conversations about that. So if you have any suggestions for future speakers or future topics, please feel free to reach out to me. I think everyone has my email, but I'll put it in the chat just in case as well. I'd love to get additional ideas. And I hope everyone has a great week, and hopefully we will see you next Tuesday. Thank you so much.
Okay. All
Thank
right.
you, Joseph.
Thank you. Thank you.